In the world of medicine, every single patient is a mystery. Every symptom, that's a clue. A doctor's mind is basically the scene of the investigation, where piecing together all that evidence isn't just some fun puzzle. It can literally be the difference between life and death. So, come on, let's put on our detective hats and solve our first case. So, we're going to start with a question that throws you right into a super high-stakes scenario. An infant is vomiting. Now, that's a really common symptom, right? But one very specific variation of it is like a blaring alarm bell. Any idea which one it is? Every great investigation really starts with that one question, the one that just cuts right through all the noise. And in our first case, that one question is going to reveal a life-threatening emergency that's hiding in a really common symptom. Okay, so picture this. You're in the ER. An infant is brought in, sick and vomiting. Now, there are a ton of potential causes, right? Could be anything from a simple infection to something way, way more serious. But as a medical detective, your first question isn't how much or how often, no. It's what color. Because in this case, the color changes absolutely everything. And there it is, green, the color of bile. You see, bile-stained vomiting in an infant is always abnormal. It's a 5-alarm fire, and it's signaling a possible malrotation with volvulus, which is a twisting of the bowel that cuts off its own blood supply. The crucial point here is this is not a wait-and-see situation. No way. This is a case that needs an urgent surgical referral. We're talking within hours to prevent permanent damage. All right, let's open up our first case file, pediatric alarms. In these cases, the patients are tiny, the clues can be super subtle, and believe me, the stakes are incredibly high. Okay, our next case. A 2-year-old boy comes in with a fever, hoarseness, and this really strange cough. You get an x-ray of his airway, and what you're looking at here is the classic steeple sign. See how the trachea narrows to a point? So, what story is this x-ray telling you? This x-ray is basically screaming croup. The steeple sign confirms it. You also notice the child has some mild retractions when he breathes, and that's a key clue to how severe this is. It's moderate. And so the diagnosis leads you straight to the treatment, a dose of oral dexamethasone to bring that inflammation down. Case solved. Let's move on to our next pediatric puzzle and see how this all builds. A 4-month-old isn't gaining weight. His mom says he gets out of breath just from feeding, and he's already had several respiratory infections. Now, these symptoms might seem totally separate, but in medicine, you have to look for the connection. What could possibly link failure to thrive with shortness of breath? Well, it turns out all the clues point away from the lungs and directly toward the heart. When you listen with a stethoscope, you hear it, a pansystolic murmur, sort of a whooshing sound between heartbeats. And that confirms the diagnosis, a ventricular septal defect, which is a hole between the heart's 2 lower chambers. It's actually the most common congenital heart defect, and it explains everything. The trouble feeding, the poor weight gain, all of it. All right, now for our second case file, the decisive clue. Sometimes a diagnosis doesn't come from a big collection of symptoms. Sometimes it all hinges on one single pivotal piece of information, a pattern, a specific complaint, or a key finding on an exam. So consider this. A 12-year-old boy was just getting over a cold, but now, about 12 days later, he starts complaining of weakness in his legs. And then, over the next few days, that weakness starts to creep upwards, and now it's affecting his trunk. So what is going on here? The key here isn't just the weakness, it's the pattern. You have to notice how the paralysis is ascending. It's starting in the feet and moving up. You combine that with the loss of deep tendon reflexes and a spinal tap showing elevated protein, and you have the unmistakable signature of Guillain-Barré syndrome, a condition where the body's own immune system mistakenly attacks its nerves. A good detective always considers multiple suspects, and in medicine we call this process a differential diagnosis. As you can see, both Guillain-Barré and Bell's palsy can pop up after an infection. But look at the key difference. Bell's palsy affects one side of the face. That ascending weakness we're seeing? That is the unique clue that makes Guillain-Barré the clear diagnosis. Okay, next case. A 23-year-old woman comes to your clinic. She missed her period 6 weeks ago, and she's got abdominal pain. Now, she could have some vaginal bleeding, lower abdominal pain, tenderness, but among all of these potential clues, which one signals a true emergency that just cannot wait? This is it. This is the decisive clue. Shoulder tip pain. It seems totally unrelated, right? But it's the most important sign of a ruptured ectopic pregnancy. Why? because it means there's blood in her abdomen that's irritating the diaphragm and the phrenic nerve, and that nerve refers pain all the way up to the shoulder. This isn't just a symptom, it's a signal for immediate life-saving intervention. Let's look at another case where the patient's own words are the most important clue you have. A 55-year-old plumber comes in urgently. He's suddenly seeing floaters, these little specks just drifting in his vision, and also flashes of light. These are definitely alarming symptoms, but it's his next description that really cracks the case. He describes it like a curtain coming across the eye. And that phrase, that specific, vivid description, is the absolute textbook sign of a retinal detachment. This is where listening, truly listening to the patient, becomes the most powerful diagnostic tool you have. The mystery is solved not by some fancy test, but by a story. For our final case file, we're connecting the dots. These are the really complex cases, the ones that require you to take multiple, seemingly disconnected pieces of evidence and synthesize them into a single, coherent diagnosis. So, a 70-year-old man is rushed into the emergency department. He's anxious, he's uncomfortable, and he is in severe pain. He describes it as a sharp, intense chest pain that radiates straight through to his back, right between his shoulder blades. This is clue number 1, and it's a big one. Then you get his vitals, and whoa, his blood pressure is 189/110. Now, this isn't just high, it is dangerously high. Significant hypertension like this is clue number 2. It's not just some background finding, it's an active part of this acute, unfolding drama. So let's connect the dots. That sudden, tearing pain, that's from a rip in the aorta's inner wall. The severe hypertension is putting immense stress on that tear. And the new heart murmur suggests the damage has actually reached the aortic valve. When you put them all together, these clues paint a terrifyingly clear picture. An acute type A aortic dissection. This is a true surgical emergency where every single second counts. As we've seen, diagnosis is really both a science and an art. It's all about recognizing patterns and piecing together the puzzle, especially when that clock is ticking. And that mental framework we used earlier, it's called a differential diagnosis. It's the formal term for the detective's list of suspects. You gather your clues, the symptoms, the exam findings, the patient story, and you systematically work through all the possibilities, ruling them in or out until only the truth remains. In the end, from a simple color to a subtle pattern, the answer is almost always hidden in the details. It's about perception, deduction, and just an unrelenting curiosity. The real question isn't just what the diagnosis is, but what crucial detail will you be the one to spot next?